How many of you were with us last night at the dinner? Almost everyone. That's great. Well, we had a really good time last night. There was a nice trivia session afterward. I don't know who won that, but apparently it was pretty competitive at some of the tables. And we also had a nice time dancing, some salsa, some bhangra, some hip-hop, a whole bunch of stuff. So, people often say advocacy is hard work, but that doesn't mean it shouldn't be fun, right? So we're going to have a lot more of that kind of stuff, in future events. We're really excited to have all of you here today at the National Leadership Conference because this is our second leadership conference that we're doing. Last year was our first one. It was a bit of an experiment. We had 30 people who registered actually for last year's conference, about 50 or so people who ended up coming in the end. This year, I'm happy to tell you that we have close to 170 people that registered for the conference. And part of the reason that we believe that there's so many people here this year, and that there will be so many more next year, is that the urgency for us to reform and improve our healthcare system is growing. But not only is it growing, but there's also growing awareness of the role that we, physicians and medical students, need to have in that process. So we're excited to have all of you here today. As you know, the theme of this year's conference is Physicians Leading Change. And what this speaks to, and what our sessions and panels and plenaries will speak to, is the need for physicians and medical students to take a more active role in leading some of the changes that we see coming forward. I wanted to mention briefly a little bit about the context for where this comes from in Doctors for America. I mentioned yesterday when I spoke that when we began in 2008, that this was not an idea that was hatched by folks who were great experience in policy or politics. It was not an idea that was forged by a team of dedicated full-time organizers, but it was really an idea that was born out of a growing frustration that people like you and me had about the current healthcare system that we practice in, a recognition, in fact, that the system that we envision and the system that we currently see were worlds apart and were growing farther apart. But it was also built on a recognition that we could help close that gap. And that's what we're trying to do through the Doctors for America movement. So in the last 4 years, what we've been focused on are really efforts to build the advocacy power that is needed to bridge that gap and to create the healthcare system that all of us want to practice in and that we want patients to be a part of. Now, here's some of the things that Doctors for America has done in the past, and I wanted to recap some of these for those of you who may be new to the organization. Actually, just by a show of hands, how many of you are relatively new who joined the organization in the last 3 months, let's say, or less? So about half of you. That's good. That's good. We welcome all of you to the DFA family. So here are some of the things that have happened in the last 4 short years. We have built a diverse membership of 15,000 doctors and medical students in all 50 states. About half of these members are generalists, primary care doctors, and about half of them are specialists. The median stage of life, so to speak, for our member is about 10 years post-training. But we have people who range from first-year medical students and even pre-med undergraduates, all the way to retired physicians and everybody in between. Over the last 4 years, we have polled physicians a number of times about their top priorities in healthcare. That's how we decided what we would fight for during the health reform debate. We have built the Voices of Physicians project, which was an interactive map that placed individual physicians and their ideas for reform on a Google-based map. And this was actually used by members of Congress and the media to understand what physicians thought in their district. We've organized petition drives, which have garnered tens of thousands of signatures, and gathered stories from physicians to support a variety of specific provisions, including support for the Prevention and Public Health Fund, as well as securing and safeguarding funding for Medicaid. We've also held house meetings across the country to gather ideas from physicians on payment reform. That was a project that was spearheaded and led by Alice Blum, who is our former national field director here. We've helped DFA members also to write letters to the editors, op-eds, as well as blog posts. And I'm proud to say that in the last few years, we've had our members publish literally hundreds of these, reaching thousands, if not millions of people. We've also created the Doctors for America blog, which Chris Lillis leads, which is a unique blog because it brings a daily physician perspective to matters of health reform. And we've also spearheaded coalitions, including a coalition of 15 national medical organizations representing over 300,000 doctors and medical students which stood up and came together last summer to actually prevent harmful cuts to Medicaid during the debt ceiling negotiations. And I'm proud to say that we, along with other partners, were able to help secure funding for Medicaid during those difficult times. Now, throughout all of these efforts, physicians and medical students were able to lead and represent an important voice in the debate over healthcare reform. And thanks to the efforts of many of the people in this room and thousands and millions of people not in this room, we were able to together pass a strong health reform law that is now set to cover over 30 million additional Americans, that's set to provide some of the greatest protections to patients that we've ever seen through legislation. That is also now setting the stage for the big changes that we need to make in how we deliver care, so that we can finally build a system that is not only more efficient, but also more effective in the care that it delivers. This is something that we did in a relatively short period of time, after decades, though, of waiting. And together what we've done is we've built a movement in the last 4 years, a movement that has never been seen to do something that has never been done. And that is something that all of us can be proud of. Now in 2012, as we touched on last night, we're now called to perhaps meet what's one of our biggest challenges. Because what we've seen over the last few months alone is that as the November elections approach, we're seeing increasing efforts to weaken and tear down elements of healthcare reform. All of us who supported efforts to pass a health reform bill recognize that it is not a perfect solution. All of us recognize that there is more work to be done, and all of us recognize that this is but a first step toward the vision that we see. But what all of us also know is that while this is a first step and not the entire step, it is an important step, and one that we must build on to do further reforms. This is ultimately a question about whether we move forward or backward in our healthcare system. And what we are saying is that as a nation, as providers, and as people who care for patients every day, that we want to move forward. We want to build on the reforms that we've passed, and we ultimately want to then focus on the next steps that come thereafter. The trouble, though, is that there are fewer and fewer voices speaking out for that. And part of this is driven by the fact that there is widespread confusion about the law. There's also a sense of disempowerment that has unfortunately spread among people, where folks feel even if they do support the law, there's really not much that they as individuals sitting in their clinics or in their hospitals can do to fight back the larger, more powerful, far more financially resourced forces out there that are pushing against the law. And that's why, as we announced earlier, we launched our 1 Million campaign, which is a physician-powered campaign to educate 1 million people about the real impact of health reform, but more importantly, a campaign to mobilize people to make sure that their elected leaders understand that they are demanding the implementation of healthcare reform. As we said also, this effort is an effort that's going to take place in a local basis, in towns, in hospitals, in cities, but it's also going to culminate in a march that we're organizing from the RNC convention in Tampa to the DNC convention in Charlotte. This will be one of the first times we've ever seen patients and providers stand together and demonstrate in such a way. It's going to be a unique moment. It will be an important moment, and it's a moment that's going to require all of you, your participation, your support to really make happen. And this has really been true from the early days of Doctors for America. We've never been a movement that's been powered by money, by resources, by connections, but we've always been a movement that is powered by the passion and the vision of everyday physicians and medical students like all of you. And just like it's always been, it will be that passion and the people like us that will help to make that vision and that march, and ultimately the implementation of health reform a reality. We are excited to have you here today because we begin this journey to creating this movement, the 1 Million campaign, the march that we foresee in the late summer. We begin that here today with the discussions and conversations that we'll have over the next 1 to 2 days. We know that learning and engaging in advocacy is not just about listening. We know it's also about hearing from you. And so the sessions that we've designed today are intended to not only share the unique perspective of people who have been leaders in healthcare reform, but it's also they're structured to recognize that you have something incredibly valuable and critical to contribute to that discussion, to build this movement. And that's why we've built in a lot of time for Q&A. We've also built in a special listening session, actually, which is all about hearing what you have to say, where we'll have officials from the Health and Human Services, where the implementation of health reform is really taking place, as well as folks from the White House will be coming specifically to hear what you have to say, what your experiences are with health reform, and how we can together inform the implementation of this law. So I encourage you to keep that in mind, and to, there's a saying in organizing that many of you may be familiar with called the step up or step back sort of motif, which is the idea that if you feel like you're talking too much, you probably are. But if you feel like you're not talking enough, then you should push yourself to get up and say something. And it's the latter that I feel we're often more in danger of succumbing to. So I encourage you, if you feel like you're not saying a whole lot, if you have an idea or a little uncertain about putting it forth, just know that this is a safe place of people who share your passion, who share your ideals, but we're also learning just like you. None of us are experts, but all of us are seeking to lead change through learning as well, and we encourage you to participate. The very last thing I'll say is that while this conference is a lot about education, it's a lot about advocacy, skills training, it's also very importantly about community building. And what we recognize even more clearly now than we did in 2008 are that what brings people to the table is the cause, but what keeps them there are the people. And we recognize that it's the bonds that form between all of us that are the real fuel that keeps this movement going in between the high points. And so we encourage all of you to meet folks at your table, even meet folks who are not at your table, and to spend time during the breaks and also during some of the sort of more fun events that we have, really connecting and exploring and getting to know other people. To make that possible, we've set up a few different things. The restaurant setup tonight is aimed at trying to get people who may not know each other together to just hang out at a restaurant and get to know each other a little better and enjoy some good DC food. And the boards that we've set up outside with the pictures are intended to help people learn a little bit more about each other. For example, a few of you probably know, there are fun facts that are listed on some of those pictures that I've got that few of you probably know about. I'll tell you, when I was looking at some of them last night, just before going to bed, I saw some really interesting ones. I'll actually tell you about a few of them. But one person in this room, I won't tell you who, I'll let you figure it out, is actually into competitive paintballing. And another person in this room is set to run an Ironman actually in just 1 month. Okay, very impressive. I was very impressed at least. 5 miles, not like easy. So, and there are a whole bunch of other interesting, fun facts about the people that we're excited for you here today. So with that, I would just like to say again, welcome. Thank you for being here. Thank you for your commitment to not only patients, but to the system overall. We're all recognizing that increasingly it's important for us not just to be doctors for individual patients, but to be doctors for our community, to be doctors for our states, and ultimately to be doctors for all of America. So thank you so much for being here. I would like to welcome to the stage Andrew Lork, one of our wonderful DFA leaders, who is a surgery resident in Indiana, currently doing his master's in public health at the Harvard School of Public Health, who will be introducing our first speaker, Dr. Emanuel. Thank you so much.
Good morning. The past 4 years, Doctors for America has been fighting passionately across the country for more accessible, affordable, and quality health care for all Americans. We're equipped with years of experience on the front lines of an inequitable, perversely incentivized health system. Yet our most powerful voice stems for our reverence for those who we serve, those most significantly impacted by a broken healthcare system, our patients. This week we gather to celebrate and to empower physicians leading change. Our speaker this morning epitomizes the doctor as an agent of change in patient care, medical ethics, and health policy. Dr. Ezekiel Emanuel is the Vice Provost for Global Initiatives and the Diane S. Levy and Robert N. Levy University Professor and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. Dr. Emanuel received his Master of Science in Biochemistry from Oxford University, his MD from Harvard Medical School, his PhD in Political Philosophy from Harvard University, completed his residency in internal medicine at Beth Israel Hospital in Boston, and went on to complete his medical oncology fellowship at the Dana-Farber Cancer Institute. He's also a fellow in the program of ethics and professions at the Kennedy School of Government at Harvard. He's the founding chair of the Department of Bioethics at the National Institutes of Health, and held the position until August of 2011. Until January of 2011, He served as a special advisor on health policy to the director of the Office of Management and Budget and National Economic Council. Dr. Emanuel also served on President Clinton's Healthcare Task Force, the National Bioethics Advisory Commission, and the Bioethics Panel of the Pan American Healthcare Organization. He's published widely on medical ethics, doctor-patient relationship, end-of-life care, and health policy. He's received numerous awards, including election to the Institute of Medicine and the National Academy of Science, the AMA Burroughs Welcome Leadership Award, and the President's Medal for Social Justice from Roosevelt University. Dr. Emanuel has also been a close friend to Doctors for America, a close advisor, recently led the jog on the National Mall to roll out the 1 million campaign. Profoundly successful event from all involved. So with that, I'd like to welcome Dr. Ezekiel Emanuel to the stage. Thank you.
It's a great pleasure to be here and to see you all. And just on a personal note, 40 some odd years ago, my father resigned his position, his membership in the AMA because they refused to endorse Medicare and Medicaid. So it is good to see doctors on the other side campaigning for a better healthcare system adequately. And I do think we've reached an inflection point in American history where we can, I hope, count on doctors to be at the forefront. You know the problems of the American healthcare system. In 2010, the last year for which we have reliable data, the United States spent $2.6 trillion on healthcare, and that increases at more than $100 billion per year. To give you a slight context for that, that makes the American healthcare system the 5th largest economy in the world. We also have tremendously uneven healthcare quality. Many of us work at premier academic centers which have great quality, are the envy of the world. But we all know that the quality across the system is quite uneven and affects even people at great institutions, whether it's through hospital-acquired infections, other errors, readmissions, not getting proven care. And then, of course, we have the 50 million uninsured in this country still. We've been trying to reform the healthcare system for 100 years. In the 1912 election, Teddy Roosevelt campaigned in part on universal health care coverage. That disappeared from the national agenda with the start of World War II because universal health care coverage was associated with things German, because Bismarck started it, and also labor, which many of you may not know. Samuel Gompers opposed the government getting involved in health care reform. Franklin Roosevelt pulled universal coverage out of the Social Security bill because he thought that organized medicine would oppose it and it would sink Social Security. Harry Truman campaigned vigorously in 1948 for universal health care coverage and was defeated by the AMA. In the 1960 election, amazingly enough, we had 2 presidential candidates, both of whom were for comprehensive health care reform. Richard Nixon and John Kennedy campaigned for universal health care coverage. And when Kennedy got elected, nothing happened in Congress. And when Kennedy was assassinated, Lyndon Johnson took up his mandate and said that Congress had to complete his agenda, including universal health care coverage. Nothing happened until Lyndon Johnson won a landslide victory in the 1964 election, and we did not get universal health care coverage. We got Medicare and Medicaid, 2 huge steps forward, but as we know, far from universal health care coverage. We know that because we have 50 million people uninsured today. In 1972, we had an unlikely alliance. We had Richard Nixon in the White House for universal health care coverage. We had Teddy Kennedy in the Senate supporting it. And Wilbur Mills who was then chairman of the House Ways and Means Committee, the most powerful committee when it comes to healthcare reform, all agreeing we would get, finally, comprehensive healthcare reform in America. And then in 1974, as they're working out the details, Fannie Fox happened. Some of you, most of you are not old enough to remember the name Fannie Fox. She was an exotic dancer who happened to fall out of the car with Wilbur Mills at 2 a.m. into the tidal basin here in Washington, D.C. A huge scandal. And up went healthcare reform with that scandal. 1993, President Bill Clinton tried to get comprehensive healthcare reform. And in part because doctors abandoned the effort, big business abandoned the effort, the failure was overdetermined. Finally, in 2010, March 23rd, 2010, we got comprehensive healthcare reform signed into law after 100 years of trying. It is a world historical event. Now, I'm an optimist, except of course when I'm a pessimist, but I am an optimist about the bill. And I think it is undeniable that because of this bill, American healthcare will be better. It is inevitable, will be better by 2020. That is not to say that the road there will be smooth. There will be plenty of bumps along the way. Anytime you have a major transition in any society, there are going to be bumps. There's going to be successes, there are going to be failures. If we expect this to be smooth, we have unrealistic expectations. We, not just in the room, but we in America. Many things we try will fail. That's a good thing. We'll learn from the failures, and we cannot expect to bat 1,000. That is just an unrealistic expectation. You go out to Silicon Valley, to all the great technology companies, for every great success of Google or Facebook or what have you, there are many, many failures. Indeed, executives who haven't failed there are not considered to be good, because you cannot possibly succeed until you fail. But it is very, very clear that by 2020 we are going to have a much better healthcare system, largely catalyzed by the Affordable Care Act. Why can I be confident of that? Well, unless the Supreme Court screws up royally, we are going to get universal coverage in this country. We're going to have a mandate. We're going to have subsidies for people. We're going to have other people on Medicaid, and everyone will be able to get health insurance. Now, there will be a few people who won't take it up, but we will have the machinery and the infrastructure and the framework to get everyone covered. First, on the coverage thing, solved by 2020. Second, on the quality side, by 2020, we're going to have interoperable electronic health records for all Americans, and we're going to have solved that problem. We can be sure we're going to have fewer hospital infections, fewer hospital medication errors, and fewer other errors in the hospital. The major efforts started now and in the bill have focused considerable attention by hospitals on improving the quality of care. Through PCORI, we're going to have a lot better information about what interventions work and which ones don't, and for which subpopulations they're best and most effective. So that'll inform our decisions as physicians as well as our patients' decisions. We're going to have a lot better quality metrics that can be collected electronically so that we know how well we're doing and how well we're not doing without having to conduct major studies every few years to assess things. That will focus a lot of attention on improving care. We're going to have a readmissions policy that'll have us focus much more on keeping patients healthy and out of the hospital. So I think it's pretty undeniable. For Americans, we are going to have a dramatically improved system in terms of quality. And then there is cost. Over the next decade, we're going to try a variety of reforms to reduce healthcare costs. Some of them are going to fail, undoubtedly. Some of them are going to succeed, and we're going to follow that path better. Second, I think through the reduction of hospital infections, reduction of readmissions, and many other things, we're going to save money. I think also because of comparative effectiveness, we're also going to get rid of a lot of unnecessary tests and treatments. I am actually quite optimistic, having gone around the country and seen a lot of the activities, whether it's at insurance companies and payers, whether it's at the hospital level, whether it's at the practice level, that we will get to that sweet spot of higher quality care at lower cost. So I think on each one of the key metrics of healthcare reform, whether it's access, quality, or cost, we are inevitably going to be better in 2020, largely because of healthcare reform. So I want to take a few minutes and tell you what I think is going to be the major change, which is going to be a major change in our delivery system for getting better care to our patients. We are trying a number of things already around the country. And as I like to say to people, actually improving the American healthcare system is not rocket science. And I actually mean that literally. Many of you may remember some of your physics. In the early 1960s, when President Kennedy announced that we were going to go to the moon, there was only one rocket fuel that we theoretically knew of that could escape the Earth's gravitational pull and actually get a rocket up to the moon. Liquid hydrogen and liquid oxygen. And we had actually never tested. You need a 3-stage rocket because of the amount of power you can create. We had never tested that rocket system until 1962. We literally had to create rocket science to get to the moon. Well, in healthcare, we don't literally have to create the solutions. We actually have successful models across the country. Our problem is twofold. One is to change the payment system to incentivize those successful models much more consistently. And second, to actually replicate them in different contexts, different medical cultures, different practice arrangements. Those aren't trivial, and as I said, sometimes we're going to succeed, sometimes we're going to fail. It's going to be a bumpy road. But in the end, we are going to have success. So let me tell you what I think the future holds. And I think, again, we're going to get to this place pretty inevitably. If you look around the country, I'm going to focus on group health of Puget Sound and one of their experiments in medical homes. But I think there are lots of other cases. There's CareMore in Southern California. There are groups doing these things all over the country. What does it look like? Well, the first thing is it doesn't look like lone doctors working alone. It looks like healthcare teams with doctors, working with nurses, working with other health professionals, pharmacists, medical aides. It looks like smaller patient panels for doctors so that they can really focus their attention on patients, especially with chronic illness. It's patients with CHF, CAD, hypertension, asthma, diabetes, emphysema. Those are the patients who consume a lot of the resources and whose quality of care we need to improve. It's patients with chronic disease who consume 2/3 of the dollars. When you decrease patient panels, you increase the amount of time that healthcare professionals can spend with those patients, from 10 or 15-minute sessions to 20, 30, 40-minute sessions. You encourage phone and email communication. And you do a lot more in redesigning your practices. You have 24/7 access, so you're not sending patients to the EW where no one knows them. You have someone who actually knows them, has access to the electronic health record, knows their medications, knows their past medical history, knows their family treating them. You don't wait for the patients only to come to you. You have active outreach to patients. You follow their physiological key indicators. You call them to make sure they're complying with medication and other treatment interventions. You have electronic health records, so you can track patients over time in every aspect that you need to track, so that you can track physician, nurse, and other performance measures of your group. So you can have decision supports that help you manage a patient and narrow the options. You also don't just treat patients individually. You actually have team huddles. You have a shared plan. You standardize a plan for patients. You also create specialized clinics for recurrent problems and get the best people you have doing that over and over. And if you look at places like Group Health, who instituted these kinds of changes, you see remarkable things. At Group Health, when they did this kind of thing a few years ago at one of their clinics, they had 6% decrease in admissions, 6% decrease in length of stay, a decrease actually in physician visits, but a dramatic increase in telephone calls, 80% increase in email communications, and remarkably, they saved $1.50 for every dollar invested in the re-engineering process in just 21 months. And even more remarkably, they had tremendous boost in physician, nurse, and other morale because the health staff finally felt like they were practicing the medicine they were trained to and not simply doing things that got reimbursed. And as I said, this is not only at Group Health. There are plenty of other places that have done this. CareMore in Los Angeles is 18% below cost compared to others and dramatically higher quality. Just to give you one indicator, CareMore has 60% less diabetic amputations than its competition in Southern California. We can do this. Now, it can't be done alone. Certain things have to happen. We need payment reform that incentivizes doctors for keeping patients healthy. We also need physician leaders, because these things do not happen without physicians taking the lead. We know over and over that if physician culture is negative to these kind of integration efforts, they simply will not happen. That's where you come in. You need to take the lead, not just in political advocacy, but advocacy within the medical profession, and arguing why this is pivotal for the healthcare professions to lead. These changes are going to happen. They can be imposed on us from outside, or we can take the lead and introduce them ourselves. Let me end with a few recommendations. The first is to stay engaged. Doctors are an incredibly powerful group in this country. Congress listens to you. Not if you're just one-on-one, but if you contact people from your congressional delegation with very specific opinions, 4 or 5 physicians from a congressional district have a lot of voice. You can't call every day, right? Then you just become a crank. But targeted on very specific things that they either have to decide or vote on, very crucial. Don't underestimate your power. The other thing is, as I mentioned, you need to become leaders in the organized medicine. They have power, those groups. You can't just leave it to the old fogies who don't necessarily want the change. Now, when I teach my students at UPenn, I a bit with tongue-in-cheek end with 4 recommendations for physicians. Here's my tongue-in-cheek recommendations. Anyone quoting me, remember I said tongue-in-cheek. First, don't go into radiology unless it's interventional radiology. It's going to become a commodity and you're going to become unemployed. Because we can send x-rays anywhere in the world, and once the reimbursement system gets fixed, we will send them anywhere in the world. Second, don't do general surgery. You can consider transplant surgery. But if I'm right, you're going to see a decrease in unnecessary procedures, and there are lots of them, whether they're elective knee surgeries, C-sections, etc. Now, transplant surgery is different. We have a shortage, and no one is ever going to reduce such life-saving stuff, even if it's very expensive. Third, don't buy hospital bonds. I know I don't look like an investment advisor, and I wouldn't take my advice either. But there are 4,800 hospitals in this country. They don't have that many of them, barely have over 50% occupancy rate. And if these changes work, we get improved quality or decreased cost. One of the major places it's coming out of is hospital admissions. The readmission rate is going to go down. The complication rates are going to go down. You're going to keep people with chronic illness healthy and out of the hospital. So those bonds, they're not a really good investment. And the last thing I would say, and I mean this perfectly seriously, and I'm actually surprised I make this recommendation because 20 years ago when I was training, I wouldn't have made this recommendation. Management training is critical. Doctors have largely been known for their incompetent management, and the healthcare system shows it. I think going forward, the ability to manage, the ability to strategically plan, to create teams, to lead change, to understand the financials, all going to be critical. I recommend to students to think about doing an MBA, but not to go to Goldman Sachs and not to go to hedge funds, but to lead the change in the healthcare system from an authoritative position. So with those recommendations for your career and your future investments, not to be taken too seriously, thank you very much, and I look forward to your questions.
We have time for a few questions. We have mics walking around the room right now.
Thank you very much for your talk. I've recently moved down to New York City after being in Boston for 15 years, and so I'm meeting resistance that I never thought I would, because New York City is a cottage industry. Half of them don't even take insurance. So I find my colleagues at Cornell very resistant. I also find that EHRs don't talk to each other. So while it's really nice that I can go home and see my patient records as I did before, still don't have the ability to communicate when they go outside our system. And the other question to you is, with smaller panels, we already have a shortage. As we bring 30 million new into the system, how are we going to address that?
I got it. First, yes, New York City may be the last place in the world to change. You have Park Avenue onesies and twosies. You don't have a lot of organization. You have a lot of fragmentation. Rest assured, it will change just like everyone else. It cannot keep at that same cost. There's plenty of resistance to it. So, patience, 2020 is what I said. The idea that we're going to change the fifth largest world economy on a dime, ridiculous. It's going to take a decade, but at the decade, even New York City will change. Second, on EMRs, again, you know, it's taken time, but if you look at the uptake of electronic health records from the data announced by the ONC and HHS, dramatic improvements over 2 years. We have 400 new companies in the electronic healthcare space. Do not evaluate what the situation will be in 2020 in terms of the ease of use by what exists today. It's a huge amount of investment, of ideas and innovation in that space, and we are going to see it come out. Those of you who are old enough to remember, you know, Apple did not invent, right, touch-screen pads. They existed in the late 1990s, and they never caught on because they were not sophisticated, right? That doesn't mean that technology, if you concluded in the late 1990s and say 2000, that technology is going nowhere, right? You would have been wrong. There is innovation. This is a space of huge amounts of money, tens of billions of dollars. We're going to have a lot of innovation over time. You know, there was a time, way back when, before most of you were born, I think, when Apple did talk to PCs, right? Go on. It's not going to be that hard. And again, by 2020, that's the date to keep in mind. Don't create unrealistic expectations, and I think, unfortunately, we probably did some unrealistic expectations. You're going to have healthcare reform. It's changing. this idea of shortage, okay? Let's get clear. On what basis is the manpower shortage predicted? Well, you look at the number of docs per population and you extrapolate. Most of us ought to be quantitatively sophisticated enough to know that is a crappy methodology. All right? First, in Massachusetts, what happened when they added hundreds of thousands of new patients to the system? Any increase in wait times for family medicine? Or internists? Or specialists like cardiologists? Massachusetts Medical Society, Zippo, no change in wait times. 2, notice what I said. Right? You're going to create teams. We're going to have task shifting. So what doctors used to do, that a nurse can do, or what nurses used to do, that a medical assistant can do, you're going to see different task shifting. You also see, when you do this right, you increase the communication electronically, and you don't need as much office visits. The idea that what the AAMC says in terms of physician shortage by extrapolating doctors per population does not conceive of the fact that we might actually change the delivery system, who and how we deliver care. Again, will it be bumpy? Yes. But by 2020, I do not think that is going to be a problem. And as you go forward, remember, use of the American healthcare system is not even. It's lumpy, bumpy. The people who use the system, right, are frequent flyers, all with chronic illness. When we improve our care of them and keep them out of the hospital, we actually free up people. And, by the way, there will be fewer radiologists and there will be more primary care doctors as a result.
Hi.
Tell us who you are and where you're from.
Sarah Williams, I'm from New York, and I am a former primary care internist and now a psychiatrist. So my question is, where do you see mental health care fitting into this vision of the future, and especially into the team approach that I think we're all working towards?
Well, I think one of the things that you look at, if you look at the data, is that anytime patients have chronic illness, there's a tendency to be depressed. There's also, if they are depressed, it worsens the healthcare utilization. So I think you're going to see the initial wave, if I had to predict, is going to be focusing on doing better on traditional quality metrics. And then we're going to hit a wall where it's going to be very important to intervene on the mental health side, because that gets you over the hump. So let me give you an anecdote as to why I sort of suspect that's going to be the case. If you look at Johnson & Johnson, which is the company probably with the longest track record on worker wellness programs, they've been doing this since the 70s, and they have unbelievable success getting patients, getting their workers to take their health risk assessments, to getting them to cutting down on smoking. I think their smoking rate is 4%. To get them exercising, etc. They find that they can access about 70 to 80% of their workers, and the last 20 to 30%, no matter what they do, they pay them money to do this, they do all sorts of other encouragement, doesn't happen. Why? Those are all patients, all employees with mental health issues, whether it's situational depression or other anxiety, other problems at home. And so they've actually recently, about 3 years ago when I looked at this last, bought a couple of mental health, behavioral health firms to try to begin targeting those people, because it turns out those are now their highest cost users in the system on average. So I think we're going to get a lot of the junk out of the system on the regular traditional services, and then we're going to hit a wall, and mental health is going to be the next big place that we have to focus on, because we know that higher mental health problems among chronically ill, and that when people have mental health, it costs a lot of money. Jack!
Hey, Zeke, thank you.
Tell everyone who you are.
Thanks for your remarks and your challenge. Jack Lewin, I'm a general internist, had a long history I've seen healthcare from many points of view, on hospital systems, public health in Hawaii, recently the American College of Cardiology for 6 years, and now I freed myself up to try to work on these issues and move the Affordable Care Act and this whole agenda along. My question to you, Zeke, is the issue of our accountability as physicians in this process. Not only should we be working on the advocacy side politically, But if we decided that we're going to take charge of systematic improvement of quality, we've got claims data, which is helpful in some ways, pointing at problems. We need the clinical data. And the one thing that cardiology and cardiothoracic surgeons have led the way in is getting the data across the hospital system and now the outpatient to give people real clinical data to track their progress. What do you think about that? Because I believe if we as the physician community decided that is our commitment and accountability, we can get that done. It's not that expensive. It's threatening to some people. But what an opportunity. What do you think about it?
Yes. That's what I think. Yeah. we have to.
How do we get there?
Yes. So I think that we are going to, again, slowly but surely get to a position of what I like to call fulfilling the transparency imperative. We need to have these data available. We can't figure out how to solve problems unless we see the problems. And we can't see the problems unless we have the data and we know where they are. We can either be always championing the fact that everything we do is great, or we can recognize we're not so great. Now, where is the biggest resistance to that? Well, it's in our great institutions, because we want to know, is the Mayo Clinic really the Mayo Clinic? Or is it not so great and hotsy-totsy in everything it does? Well, the data suggests it's really good in certain areas, but maybe not so great in other areas. And unless we're willing to fess up to that and begin repairing and fixing the problems where we're not so great, we're not going to make progress. So I think having the data accessible is going to be vitally important. And again, my view is you've got a lot of firms out there thinking about how to drill down into data, whether it's clinical data or claims data or pharmacy data, to really see where problems are and where we're having deficiencies. We will definitely, inevitably, start with claims data because they're available and they're easy to analyze, and we've got a lot of people experiencing it. As the EMRs get progressively better and we're able to do good protection of patient confidentiality, we will begin much deeper dives into clinical data. And again, by the end of the decade, there are going to be plenty of companies out there going to be doing a lot of analyses of those available data. And if you don't believe me, just ask yourself the following question. Exactly why did United Healthcare create this standalone group called Optum, right? Where it has three components, one of which is heavy on the analytics. I will suggest to you, because the future is a lot of ability on the analytics to analyze where the problems are. And those things are going to become much more transparent, I think, pretty inevitably. People are going to want to know where the quality is and where the quality isn't. And I think actually, by the way, everything we know about it is patients aren't actually that responsive to that quality data. But we are responsive to that quality data, right? Why is that? Well, all of you have been selected in a very Darwinian survival of the fittest mode, right? You had to get A's to get into medical school, and you had to do really well in medical school to get into the best residencies. We cultivate people who are exceedingly competitive to do well. We are driven to the A. We're not going to want our quality reports show that we're really C performers. We have not used that motivation sufficiently, in my opinion. That is a very important motivation, and I think we need to use it a lot more. Yeah.
My name is Howard Oslinson. I'm from Durham, North Carolina. You sort of started to touch on the answer to my question, but I'm puzzled by why, given that we would all agree that the system is broken, that physicians are dissatisfied, quality is an issue, cost is an issue, why are there 200 of us here, and why not so many more? I don't know, perhaps you have an insight about why there's so much apathy or disinterest or disbelief among our brethren that this is our responsibility and that we can and should do something.
Let me make two suggestions along those lines. First, I think my last recommendation to you was more management. Doctors are bad managers, including political organization and things like that. So we're not very good at coming together and actually organizing. I would say second, I'll give you three answers. Second, we have been, in addition to being bred and cultivated and trained for excelling at quality performance and getting A's, we're also been trained to be very individualistic. And so coming together, to work together, is not something docs are tremendously good at. Even in organized medicine, by the way, it's more like disorganized medicine, right? Talk to anyone who's been to an AMA meeting, right? It's mayhem more than organized advocacy. And the last thing I would say is that docs feel very threatened by healthcare reform. I would say that the administration did not do a fantastic job of educating the physician community, keeping them on board, getting all their ideas for how to change things. And so while docs are very dissatisfied, if you look at the polling, pretty negative in general, I think it's not clear to them that this path is going to lead to a better arrangement for them. And, you know, you can be really, really pissed off, but you're not going to come and try to make a change if you don't think at the other end it's going to be better. So we need to do a better job of convincing and trying to persuade docs why this system actually will be in their interest. And let's be honest, for some docs, it will be a tremendous improvement. But for radiologists and general surgeons, maybe not such a tremendous improvement. And the last piece is, of course, the money piece, right? Remember, we do want, you know, better working environments. We really want to take care of our patients, but there is the money piece. But on that score, let me say the following. We are spending $2.6 trillion probably now, you know, 2.7 in 2012 will probably be $2.8 trillion on healthcare. No one, even when we talk about cost control, no one, let me repeat, is talking about taking us from 2.6 or $2.7 trillion to $2 trillion. We're talking about slowing the rate of growth. There's going to be plenty of resources in the system. They're going to be reorganized, but there are still plenty of resources in the system. We are not removing employment. We may cut it here and add it there. But no one is talking about healthcare costs going down. We're talking about slowing the rate of growth. That's what cost control means. Control